Okay, we're almost finished with BJ, and then we're going to break here for a bit. So in the summer before grade 5, BJ is seen by the community pediatrician and reviews all the information, the previous assessments. He thinks BJ has ADHD, but also thinks that autism is a reasonable question and makes a referral to the BC Autism Assessment Network. There's some discussion with the family about treating the ADHD, but they've heard such negative things about it that they don't really want to go there until they rule out autism. But given the behavioral concerns, BJ gets started on some risperidone, and we'll talk about that later. There's some discussion. Actually, let's skip that part there. Okay. So BJ has this assessment. This is the BCAN assessment and the autism assessment. What we learn is this is a kid with long-standing social challenges, which really have become magnified in the last few years. There's a lot more social marginalization and apathy being reported. The parents say his language has always been kind of immature, but really in the last couple of years have they really appreciated how his social communication is problematic, that he's having real troubles maintaining the flow of conversation with his peers, and they see this compared to his siblings. His interests tend to linger longer, like Pokemon. He gets into something, and he kind of stays with it for a lot longer. And this kind of historically going back was something they saw with Thomas the Tank Engine, and now with Pokemon as well. He does better with routine when you ask them about kind of rigidity and so forth. And minor changes in routine he gets kind of perturbed by. When you ask him about repetitive behaviors, these RRB or RIRB. He did do some spinning when he was younger, but other than that, no flapping or other sorts of behaviors that are much more typical. But there are lots of sensory issues, lots of sensory aversive issues. On observation, this is a boy who acts like a younger child. So rather than acting his age, he's really comes across as a boy who's more like a 6, maybe a 7-year-old kid. Very impulsive, needs a lot of scaffolding to manage him, to keep him focused, to keep him interactive. And initially he's a bit shy, like a little kid, but he warms up pretty quickly when he realizes he's not getting a needle, and he starts to play, and he's interactive, and he wants to show things, and it's a pretty fun session. But he does seem to be a little bit lower than his age. His language is less complex. And when you have less complex language tends to be more repetitive. You have less to generate language from. You have a smaller library of words and phrases and so forth. Then you will hear the same things more often. And so younger language does, by definition, tend to be a bit more repetitive. So he's using certain phrases a little bit more than you would expect, but nothing obvious in terms of kind of odd phrases or things that he's picking up from TV shows or from cartoons. And at his level, you can actually do some back and forth conversation. He's extremely animated. In fact, a little too animated. So you see me like this. He's on steroids. He's in your face. He's got lots of expressions. He's really wanting to kind of use every modality available to him to communicate what he wants at that moment. Needs lots of reminders to stay seated, not to touch things, but generally he's compliant, but needs another reminder a few minutes later. Eye contact's not great. No, he's like, it's really hard to get him focused on you. He look at you and he's like off over here, and so as a result, he's missing a lot. So when I'm frowning at him saying, stop, he's not picking that up, and I have to actually use my voice. So I get some of the issues that the school's saying, like he misses a lot. He's missing a lot of cues here. He's wearing a Pokemon t-shirt, right? He comes in, and you wait 20 minutes, 30 minutes, Pokemon doesn't come up as a topic of conversation. So finally got like, come on now. What about your t-shirt? What about Pokemon? And he gets interested. You know about Pokemon? Cool. And he starts telling you about, the various characters that he's really into right now and the different cards he has. It goes on for a couple of minutes, and then you try to shift topics, and he goes, fine. No problem moving on beyond it. He likes it. He gets excited by it, but no trouble transitioning off there. You don't see any repetitive behaviors. You don't see any repetitive mannerisms. You do hear some noises in his throat sometimes, and kind of squints a little bit every once in a while. Okay, I know I'm past my 10, 15. Can I go another 5? So now we get to look at my second schematic, and we're going to go through this in a variety of different ways, but I'm going to introduce you to it initially. Actually, I think what I'm going to do is I'm going to introduce it to you, and then we'll break, and then we'll continue. Okay, so this is a schematic of how I understand looking at differentiating symptoms that are part of autism spectrum disorder, as opposed to the same sorts of symptoms or features that can be seen in other disorders. So what I've done here is I've created a table which on the left here you have a series of symptoms that are derived from the autism diagnostic interview, the autism diagnostic observation schedule. These are behaviors that we are looking for that help us identify autism in a child. So a solid green bar, the first solid green bar, indicates that in autism, obviously, any of these things that we're looking for can be present. Not in every child will they all be present, but they certainly can. And as you move horizontally along the table, you have, I've placed a whole bunch of other childhood conditions. And if there are green boxes within those bars for each condition, it indicates that that particular symptom could actually exist in the other syndromes. So, for example, if you look at the first line here, ADHD, gaze atypicalities is green, meaning that can kids with ADHD have gaze atypicalities? Yes, they can. Often very brief eye contact, very common in them. But you tend not to show any deficits in peer interest. Kids with ADHD are pretty peer-oriented. They want to interact, so that area, that box is marked red, indicating that you wouldn't typically see that associated with it. Now, what I want you just to understand, just in terms of, and we're not going to talk about the ADI and the ADOS at all today, other than this one slide, which basically tells us that the symptoms derived from the ADI and ADOS are actually very, very, very closely linked to what we know to be autism. So have high specificity and high reliability and high sensitivity. What they don't do very well is really separate out autism from psychiatric comorbidity. And that's going to be the part of what we're going to be talking about for the rest of the day. And so what I'm going to do now is take that complex table that I've shown you and slice it up a little bit for you and break it down and illustrate how this stuff plays out in real people to some degree. So the first thing I want to do is to think about developmental disabilities as a whole. Now, you remember when I was talking before the break about the ADI and the ADOS, how they're really good tools when it comes to differentiating autism from other intellectual disabilities. And this set of slides illustrates that. So what I've done here is I'm going to stack up against autism the other developmental disabilities. So the first bar we have here now is intellectual disability, what used to be called MR or developmental delay. But intellectual disability, individuals with intellectual disability certainly can have a number of features or behaviors that can also be described or caught within what we would see in autism. So, for example, kids or individuals with severe or even profound intellectual disabilities will often have repetitive motor mannerisms like flapping, or they'll have sensory-related behaviors that are part of it as well. People with intellectual disabilities can have troubles with social integration. So you can see some areas of green within that. At the same time, there's quite a distinct swath of red across intellectual disability, which allows us to fairly confidently separate out intellectual disability from autism spectrum disorder. Now, conceptually, let's kind of think about communication disorders as a group. Now, I've just kind of grouped them here. This includes language disorders, receptive and expressive language disorders, and speech disorders to some degree as well. And again, conceptually kind of outline the areas that individuals with communication disorder alone might have features or behaviors that could seem like things that we would see in autism. And again, what you end up seeing is that there are areas of overlap, areas where the symptoms can look similar, but there's also fairly distinct areas of difference between the two. So, for example, we know with communication disorders, one of the things that individual communication disorders can have is unusual language use in and of itself. And so they can have evidence of some inappropriate speech or language that can sound like the sort of things we might see with individuals with autism. But again, large swaths of red amongst the communication disorders, so it's not that challenging to separate a communication disorder from an autism spectrum disorder. I've grouped here learning disorders as a general category, so this would include verbal, nonverbal, reading disorders, and some of the literature that describes some of the difficulties that individuals with certain types of learning disorders have. And so, again, we group here, we see there's areas of overlap, but also areas of distinction. And just for completeness, if you have a child with a developmental coordination disorder, there are some things that can happen with them that can look a bit like the kids with autism. Not a lot, but a few things. They can have clumsy motor mannerisms, and so sometimes their gesture use might not be very good. Sometimes kids who are clumsy have difficulties with social integration and friendship, so there can be some social issues associated with it as well. But again, large areas of distinction. Now, if you remember, actually I don't think I told you this, so you can't remember. In that initial 580 kids that we were talking about, and I said, about 80% of them had, or over 80% of them had a developmental diagnosis across the age span. Actually, there's another table that I didn't show you which indicates that even with them, the developmental diagnoses are complicated. That, if you remember, I was talking about how some kids had one psychiatric diagnosis and two and then three. It goes the same way with developmental diagnoses. And in that 580 kids, actually 15% of them had 3 or more developmental diagnoses in addition to autism if it was present. So this would mean a kid who has DCD, a learning disorder, and an intellectual disability, for example. Now, if you just do this kind of theoretical experiment and say, okay, we're going to create this very, very complicated kid with an intellectual disability, a language disorder, a learning disorder, and DCD, and we're trying to separate them out from a child who has an autism spectrum disorder, and you're going to ascribe up to each of these diagnoses various features, and you combine them, what you end up seeing is that the areas, swaths of red, start to diminish. Right? It gets harder to really distinguish it. At the same time, there's some really clear areas that do distinguish it. Right? And so as a rule, this goes back to the ADI and the ADOS, even with more complex developmental disabilities alone, if there's nothing else in the picture, you can generally reliably separate out the two. It gets more and more complicated the more comorbid developmental diagnoses you have. Okay, so back to BJ. If you remember our assessment of BJ, the conclusion for this assessment of BJ was that he does not have an autism spectrum disorder, but he does have, we agreed that he had a mild intellectual disability. He also has ADHD and he has a tic disorder. Associated language disorder and reading disorder are likely, but based on our clinical assessment, can't diagnose that, so some further assessment is recommended, as well as treatment for his ADHD and monitoring of his tics. Okay.